Hi everyone, today we are going to look at this radiographic case in which you will see this is a 20 years old female patient with a childhood scoliosis surgery and now presented with a right-sided lump. So let's pay attention to this frontal pelvis radiograph. So on the first glance, basically the included lumbosacral spine alignment is okay, and also the bilateral pelvic bones including the ilium, acetabulum, ischium, the pubic bones, all the pelvic rings are basically okay. So if you are new to that, basically I will screen the main pelvic ring here, which is produced by the promontory of the sacrum here, and then the bilateral sacral ala, and then here you will see the anteroinferior aspect of the sacral eyelid joints, and then the iliopatellar line, and then forming the complete ring. Eventually it also ends at the midline as the pubic symphysis. And then also do check the obturator foramen, okay? But do not only focus at the inner ring. For me, I will always check the outer side as well, because sometimes the fracture may not be that obvious, can only be picked up in one of the inner or outer side of the ring. So this is a tips, okay? And then eventually you also check the bilateral femur, but do have two review areas. Bear in your mind. One, try to see through the bone and then see any abnormal sclerosis. Sometimes it may be some abnormality at the covering acetabulum or the overlapping femoral head, okay? So there is no abnormal density or fracture. And then see through the trabecular bone at the bilateral femoral neck region to make sure there is no fracture or any abnormal bony lesion. Do not focus only the femoral neck for only fracture, because the included femoral shaft region is also very classic for bone lesion. Although this is a young patient, but in adult patient, sometimes you may pick up some bone lesion like myeloma, metastasis in the proximal femur, etc. Okay, but do notice that pelvis is actually a very classic radiograph for you to compare both sides. Without comparison, you simply cannot detach the lesion here, okay? It is really not something we will expect to see a lesion, but by comparing both sides bit by bit, you will see there is added high density with some like cortical component and also trabecular component. So there is an ossification projected above the right sacral eyelid joint. So only seeing this radiograph is pretty difficult to discern what is happening here, but surely that may be a palpable lump, and you will think that okay, if this is a palpable lesion, so should be something posteriorly located. If it is anterior, that should not be palpable, right? If it is adjacent to the SI joint. So this is something that we can combine with the clinical history. So of course, the next thing we are going to do is a cross-sectional image. And then you now see that this is actually really projecting posteriorly. This bone lesion is arising from the ilium bone here. Okay, so it is actually like a cauliflower appearance, a projection with cortexes and also some medullary bone. So such a projection is actually suggesting that it is an osteochondroma. And osteochondroma, you all know that we need to look for any sign of malignancy. Of course, the best way is to do an MRI, but if you are only having a CT on hand, do know that there is a thin layer of cartilage cap, which has a propensity of having malignant transformation. So what to do on a CT to assess for malignant transformation? One, any abnormal soft tissue swelling, which cannot be accountable by the usual erector spinae muscle. 2. Any abnormal ring and arc calcification, which obviously telling you that this soft tissue is thickened and which is chondral in nature. 3. any erosion back to the cortex of this protrusion, okay, of this bony protrusion, because when this is chondrosarcoma, it can erode back to the osteochondroma itself, okay, which are not present in this case. But mind you, if there is really painful presentation, then you need to also notice that not always sarcomatous transformation will cause a pain. Can be fracture, can be bursitis, or compression onto neurovascular bundle. These are really classic examination favorite question, for example in FRCR 2B examination, that you must know. And do prepare that the orientation of the osteochondroma can be pretty challenging for you to really know what is happening, or can be very unexpected on the radiograph. And pelvis radiograph, do compare both sides whenever you do not really see anything, especially in examination setting.